I'll apologize in advance because this is a rather lengthy lecture and there's no real great way for me to split it up into two parts. So just bear with me, take some breaks if you need to. But this is going to cover Chapter 6, Chemical Examination of Urine. These are going to be your objective slides. You should be able to do all of these as your takeaway of your lecture. Know these key terms. They have come back to haunt you from other classes and chapters. So remember them or look them up. They have to do with different disease states. When we analyze samples, there are 3 different types of results that we can get. Qualitative is something that is with letters, okay? So L for letters, if you'll remember it that way. Qualitative typically gives you just a positive or a negative result. Quantitative is a quantity, which means it's a number. When you use a quantitative result, this is something that is typically going to be the exact number. Like your glucose result was 170. There's not an estimation to it. So this quantitative result is typically something you're going to get off of an analyzer. Now you have semi-quantitative, which could be, it's also going to be numerical, but it's more of an estimation. So whenever we read your analysis results with the chemical strips or even with the analyzers, it's going to give you things like trace, 1+, all the way up to 3 or 4+. So any of these are called semi-quantitative results. Your reagent test strips, there's a few things you have to know before you even use them. Remember, anything we use, you have to use manufacturer's directions. For the most part, they're not going to differ, but make sure that you have the correct one. Some of them have only 5 pads on them. Some have 11. They vary. So make sure you have the correct one and that the instructions are based on the manufacturer's instructions. Now what these reagent strips are going to do is they're going to measure the dissolved elements. And they do this by using these chemical impregnated absorbent pads. They each will turn a different color depending on the dissolved elements that are present. With sampling, you don't need a huge amount of sample. I mentioned when we talk about the COVA system, you want to try to have that 10 milliliters because that's a good sample volume. But your sampling for the reagent strips is actually very small. So you're going to take those COVA system and you're going to dip the reagent strip and you're going to zip it. You're not going to let it sit. You're just not going to put it in, pull it out. It's a dip. So you dip it in, and when you pull it out, you're going to kind of give it a little bit of a tap on like a, either on some gauze or on a paper towel, something like that. Because if you have excess reagent on those pads, or not reagent, urine on the pads, then they can leak into the different little absorbent pad, and then that color will kind of mix up, and then you'll get an inaccurate result. So you don't want excess urine on the chemical strip. So make sure you are using your technique correctly. Whenever you're not using the bottles, you can see that it's a dark bottle. It's that way because they're light sensitive. You have things like bilirubin on there, and because they're light sensitive, you always want to make sure it's closed. You also want to close it because with like moisture in the air can cause the strips to already start turning a little bit of a color, so you don't want them open. It needs to be stored in a dry, cool place, okay? And they have to be protected from light. You don't ever want to put them in the refrigerator. Remember, we're talking about the moisture. You don't want to touch the pads, okay? So when you take it out, make sure you hold it on that end, kind of where this person's fingers are at, so make sure you do that. And we're going to QC them. Whenever we use them, we're going to QC the bottle. So that's something that you'll be doing every lab. The timing that you'll use is going to be based upon the manufacturer's directions. That's another reason we read them. You also can find the timing on the side of the bottle. You don't have to worry about timing so much when it's on the analyzer because that does it for you. However, when you're doing a manual diff, you need to set your timer so that you'll know when to read each strip. And they're on there very nicely where on the bottom we start with the ones, typically it's on the bottom, you start with the ones that take less time, and then the ones on the top are the ones that take like 2 minutes. So it can vary anywhere from like 20 to 30 seconds to 2 minutes. So you're making sure you're reading them in the order they're supposed to go. So don't read your last test at 30 seconds when it needed to be for 2 minutes, okay? Because you're not giving it enough time to color or to have a color change. I'm not going to talk a lot about specific gravity because we've talked about specific gravity a lot. But I do want you to know kind of just the clinical significance of it. With the principle, it's going to be based on the change in pKa of a polyelectrolyte in an alkaline medium. So that would be your principle of it. You don't really need to know it for your exam, but everything has a principle with all of these reagent strips. And a reagent strip does have specific gravity on it. They're measured in 0.005 intervals, so it's a really small number. Specific gravity doesn't go up very high. Remember, if you get like 1.040, that's not clinically significant, or not clinically possible, I'm sorry. That could be something maybe with a contaminant. So if your upper limit is below 1.040, then it's not going to be a very large number. Also remember that if you get 1.000, this is the specific gravity of water. So you would definitely question that type of result, and that's where you would use your refractometer to double check. When we do specific gravity, all we're measuring is the ionic solutes. So that's all it's measuring, remember, is the ionic solutes. If you have specific gravity, it can help point you in the direction of certain diseases. Of course, you have to add it with the results of other chemical testing, but it can be an indicator of tubular dysfunction or impaired absorption and secretion. pH, we will talk about in the next chapter. pH is very important when it comes to crystal identification. So we'll go ahead and say that. The principle behind it is the double indicator, methyl-redded bromethyl, blue. So it's another one of those where I'm saying you got to go in the principles. They're on every one of the slides. So memorize the principles. When you do your tools for chemical analysis with your assignment that you have, make sure that you're adding somewhere in there the principle of the reaction that's occurring on the strip. These go up in 0.5 increments, and you should never have anything that's above 8. Anything above 8 is not clinically possible. Same as if it's something below 4.5, you kind of would question that as well. You can have differences throughout the day in your pH. Whenever you have a first morning sample, it's always going to be a little more acidic. And then depending on what is in your diet, right after you eat, you have something called alkaline tide. So this is where the stomach acid secreted is going to make that pH a little more basic. So just kind of remember that can change throughout the day. Not like a huge amount, but it can be a little bit different. It helps to determine acid-base status. This is with, if you have a functional kidney, then it's going to follow the acid-base status. If you don't, then your pH is going to be kind of messed up. You also need to know interferences when we start going with these. So anything that I have on here, not so much the specifics and how the increments move, that's kind of, you need to know that, but not something you can be tested on. But you are tested on the principles and the interferences of each of these chem strips. Whenever you have a UTI, you can have an alkaline pH. Crystal identification, remember, is the first thing, well, you don't remember that yet, but when you do about crystals, that's the first thing you want to use to determine which type of crystal that you have. So always start with the pH on those. Protein, we have a protein error of indicators where we are releasing the hydrogen. That's our principle. You do need to know that protein with the chemical pads, they're specific for measuring albumin. Remember that we should not have albumin in our urine. Albumin is a larger molecule, and your glomerulus should stop that from filtering in. It should not go through. So albumin is something that we don't want in our urine. So if your protein comes up positive, that's what it is. It's this larger molecule. Now you do kind of have a little bit of albumin that's going to pass through, but it's about less than 150 milligrams a day. So it's a very small amount. Now whenever you exercise a lot, then that can increase your protein kind of, so you may have a little bit of it to show up, but that can be normal with people who exercise a lot. And some of these are changed kind of by people who have excessive exercising routines, and they'll change whenever they go a couple hours and or a couple days where they haven't done this, and everything will kind of go back to normal. So this is one of those things where your patient history is important, because rather than you get upset that, oh no, these are positive results, something's wrong with this patient, it could just be their body is doing this because of their exercise. Okay. Now you do have things like nephrotic syndrome whenever you get up to greater than 3.5 grams per day, so grams is a lot bigger than a milligram, then you can have things like nephrotic syndrome. You do need to know about the TAM horsefly, the Benz-Jones protein. So those are two proteins that you need to know, and you need to know what they are for. Your TAM horsefly is seen with distal and renal tubular diseases. And remember, your Benz-Jones protein is with an Ig-like chains. The Benz-Jones goes a lot with multiple myeloma. It's mostly when you have it, and you can get a protein clot, but whenever you heat it up, so whenever your urine is heated, then it'll still remain. So sometimes you can do things temperature-wise for testing, and it causes some type of a difference between them, and you'll see that in some other classes too. And you can identify proteins removed through electrophoresis and immunoelectrophoresis. So that also could show up with this Benz-Jones protein. Whenever you have protein on your strips that come up as positive, you can confirm with using SSA. What it is when you have protein positive, then your SSA, when you produce or when you perform it, you'll get this turbidity that will happen to the urine. And all of these procedures are in the book also if you want to look at them. We do them in lab, but mostly just an example of how to do the confirmatory test, because a lot of them aren't used anymore in labs, because there's other things that they do in addition to a urinalysis that would show whether these things correspond with what's going on with the patient or not. So we don't use a lot of confirmatory tests anymore, but you do need to know what they are and what they were used for. So SSA is for protein to confirm, and that procedure is procedure 6-2. If I get out of order of the book, I apologize, but I'm trying to get them in order. If not, just kind of match it up with the book as you go. With blood, you have peroxidase heme. So it's got a heme in it. Remember, heme is blood, so that should be a little easier to remember in your principle. Now with this, it is important that it will be specific for lyse red blood cells, hemoglobin, and myoglobin being detected. So it does detect all three. And that makes a difference, because to know what's wrong with the patient, you are going to have to look at the microscopic, which you have to look for microscopic if anything is abnormal in a urinalysis. But if you look at a patient who has a positive blood chem strip, you don't necessarily have to have red blood cells showing. So you may not see red blood cells under the scope because they're lysed. So when they're lysed, then it can cause your urine to be kind of red. It can be kind of cloudy. So urine clarity kind of helps too on identifying between all of them. But you don't necessarily have to see any red blood cells because they're lysed. But you can never have a negative chem strip blood and then see blood under the microscope. It can happen the one way, but not the other. Okay, and that's important to remember. With myoglobin, that can be passed whenever a patient has muscle damage. So that's what myoglobin is. And then we also have where, if you remember hemosiderin, which is your ferritin, If that's being released, then your urine can kind of have a yellow-brown granules in it. So that does show up as a different color also. So this is where two of those key terms come in, that hematuria and hemoglobinuria. This is where we're talking about diseases or what's occurring when you're looking at the blood strip versus the microscopics. There's two of the diseases that you need to kind of know, two of your terms. And when I talk about knowing diseases, you don't necessarily have to know anything about them yet. That doesn't come until Module 3. However, you do need to be able to know moving forward that it goes with these diseases, because this chapter is going to this unit is going to overlap a lot with the next one, because you're going to have to be able to interpret results. So kind of keep that in mind. Ascorbic acid, we'll talk about that in just a little bit, but when you start talking about stuff that causes false positive and negatives, that's a really big one, is your ascorbic acid. And your second one is going to be whenever you have a urine that's out for a long time or it's not stored at the right temperature. So those are your two big interferences, but we'll talk about that a little bit too later. Nitrite, this is with diazo coupling. Usually you'll just see it as azo coupling for the principle. Nitrite is found in our diet, and it's also going to be in our urine when we have gram-negative bacteria present. Only gram-negative, not gram-positive, only the gram-negative. And the biggest one of these is E. coli. This bacteria is going to reduce nitrate to nitrite, and as it does that, then that's when we'll see this positive on the strip. So anytime you have a positive nitrite, you want to think bacteria. And so when you do your microscopic, you may have a little bit or you may have a whole lot. So make sure those kind of go together and make sense. You can see these positive in UTIs whenever it's in the ascending of your loop of Henle, then it's very significant. If it's from the descending, then it's not as much. But you can see bacteria when you have a UTI. The thing about the bacteria that you need to keep in mind is it requires 4 hours in your bladder in order for it to convert. So if you have someone who is urinating frequently, then the nitrite may not show up as positive even though they have the bacteria, because it's not given enough time to grow, to reproduce, and therefore there's not enough of it to cause that change. It's not enough of, not in there long enough for it to be able to convert. So you do need to know that, and that's important. So like I said, just when you have nitrite, bacteria, know what they correspond with. Nitrite is bacteria. Now when we talk about leukocyte esterase, well, these are looking at leukocytes. Leukocytes are white blood cells. So if you have something positive for leukocyte esterase, that's what you need to think about. The principle behind this is also azocoupling. Azocoupling will show up in a couple of these. The specifics for this is your esterase is present in the white cells except for the lymphs. So you shouldn't see lymphs. It's not detecting lymphs. Well, not that you shouldn't see them, but it's not going to detect it. But mostly what it's detecting is going to be sorry, I lost my train of thought. Sorry. Okay, so white cells, they're going to indicate inflammation. And typically, you're going to see them in most of your renal diseases. When they lyse, they can release esterase. They would lyse in like a diluted urine, because remember, urine is water mostly. If you have an increased bacteria, increased pH or heat, any of those type of things, centrifuging it too hard, those things can cause your white blood cells to lyse. And then that would cause problems when you look at your microscopic. It can also cause problems whenever you've stored it incorrectly. Here's your ascorbic acid again. That's going to change it. So those are some things that make it change. Glucose oxidase. We've seen different types of glucose testing. Remember, we did the oxidase was also in hematology. So glucose oxidase is our principle for glucose. Only glucose is detected. You have other, we'll talk about in just a second, with your confirmatory test, this copper reduction and clinitest. It looks for all reducing substances, but your glucose is going to be the only detected on your chem strip. So these can be in different types of glucosuria, glycosuria, diabetes, gestational diabetes, any of those type things that can be found in. Remember, we shouldn't have any glucose in our urine. We have a renal threshold of about 160 milligrams per deciliter, and once our serum levels of glucose get that high, then that's when we start having that spillover, and it's found in the urine. So anyone who has any type of a problem with blood sugar, and those are the ones that typically their glucose is going to go so high. You use the confirmatory test of either copper reduction, which we call a clinitest, and that's in procedure 6.3 if you want to look at it. This kind of shows how it works, kind of the color change between all of them depending on what you have. When we do a clinitest, you need to be very aware that it gets hot. It gets really hot. You never hold the bottom of the tube. You always hold up towards the top because it's going to bubble up when it does a reaction. It's going to get real hot. So this is a copper reduction. There are several different reducing substances, not just glucose. You have things like galactose, fructose, pentose, lactose. So there's lots of different oses. Remember, so there's different glucoses. It turns this brick red precipitate when the oxide is produced. The reason that they used to use clinitest, the most one, is for if you had a negative glucose on the chem strip for anyone who is 2 years old or less, then they would do the reducing substance because they're wanting to know if the patient had galactose, and the galactose can cause inborn error of metabolism in newborns. And so any child who was 2 and less, they used to do the clinitest as confirmatory if they had a negative glucose on the chem strip. But they don't really do this one anymore. Remember, I said they've gotten rid of a lot of the confirmatory tests because these are done in your early testing on newborns. Remember, newborns are tested for several different things. When they're first born, you've got the little cards. You have blood tests that they can do with their heel stick. So because they do this testing now for that galactose to make sure whether or not the kid has this. So you don't really have to do clinical testing anymore. It's something that's going away. But it was significant for inborn error of metabolism. Ketones, there are 3 different types of ketones, but your chem strip is only going to detect acetoacetate. So this is what we're seeing, acetoacetate. That's the only one that's going to be detected. It won't detect the other 2 forms of ketones. Your ketones and your glucose go very hand in hand. So most, not all the time, most of the time, they can be positive together. Your confirmatory test, usually see it as an ACE test, but this is a nitroprusside, which also is in the principle of ketones. But it's a confirmatory test. The procedure is in procedure 6.4 in your book. And what ketones are is ketones form from your fatty acid metabolism. Ketones are for producing energy. Bilirubin is azocoupling. We've talked about in chemistry about azocoupling with bilirubin. So a lot of things you probably have already seen in chemistry. Like I said, with your bilirubin, I think with your blood, with your white cells, glucose, a lot of these you may have already seen. So it's a little easier to remember those. And other ones that just take you a little while. When you use the test strips, remember your test strips, the exposure to light can interfere So you need to make sure that you're storing them correctly. You also can have bilirubin be affected, like if your urine sits too long at room temperature, or if it sits out, then that can also cause the bilirubin to break down. So you need to remember that. You can see bilirubin positive in people who have like hepatocellular diseases. When they have hepatocellular diseases, your bilirubin is going to re-enter the blood. Your confirmatory test is the ICTO test. You can find a procedure for that on in the procedure 6.5 in your book. Urobilinogen is the Ehrlich's azole coupling, and this one, as well as the bilirubin, both of these can be affected by light exposure. They're both having to do with the bili, but they don't always show up positive together. Usually about 20% of your urobilinogen is going to be reabsorbed, and then you'll still have renal excretion of about 2 to 5%. So it's not a whole lot. So it's going through the system, but it's being filtered back into it's going through the urine, but being filtered back into and reabsorbed back into the bloodstream. Sorry, that took me a minute to get out. But some of it's going to be excreted. It's a very small amount, but that's why whenever you look at the results, urobilinogen result for a normal is not negative. Normal result is typically going to be less than 1.0 milligrams per deciliter, or sorry, that was wrong. It can be 0.2. So it's not a negative reaction because it is normal for some of it to filter through. This urobilinogen is oxidized to urobilin, which is going to contribute to a urine's normal color. So we talked about the different types of urobilin. There were several different uros that cause the color changes in urine. People who have positive urobilinogen can be people who have jaundice or liver and biliary diseases. So bilirubin and urobilinogen can go together. So just remember that. Microalbumin, we've talked about microalbumin before, especially when we did protein electrophoresis. So remember, albumin is a large molecule, and it should not be present in your urine. Now, whenever you have microalbumin, this can be with early stage kidney disease, so that's the biggest thing to remember with it. Whenever you do a microalbumin test, this is not on the chem strips we'll be using. I think on some of them, they have them now, but it's not a normal one usually that they're going to put on the chem strips, just so you know. But whenever you do have a dipstick, the reagent pad is going to detect creatinine and albumin. These are some changes that will occur in unpreserved urine. So this is table 4.2. So this was from your earlier chapters where we're talking about urine collection, storage, all those different things. But these are what you need to know. You do need to know the changes of them, whether an unpreserved urine, whether it goes up or down, increased, decreased, and the cause of it. Why does this happen? So like with the bilirubin, remember, it can decrease because you're exposing it to light. And when you expose it to light, then it causes it to degrade. So that's kind of one of them. When you have your nitrite, remember nitrite is with your gram-negative bacteria. So if you were to leave it out, it's getting warm, it's going to increase the bacteria. And as the bacteria is going to increase in the sample, then the nitrite would increase. Ascorbic acid, remember ascorbic acid is vitamin C. It's water soluble, and if you have an excess of it ingested, then it can be excreted. Ascorbic acid can cause several different interferences. So this is one of the big ones that you want to go in and look and figure out if it causes a false positive or false negative. Approximately 23 urines are going to be positive for it. This can be because, one, it could be in your diet. You're taking some type of vitamin, so you're ingesting it, you have too much of it, it's going to be excreted. It'll always interfere with blood, bilirubin, glucose, and nitrite. So those are your big ones that's going to be an interferent for. So if nothing else, remember those four. Ascorbic acid will interfere with blood, bilirubin, glucose, and nitrite. You can suspect it whenever red blood cells are present, or if you have ketones positive and you're glucose negative. Don't worry about that. But do worry about what it's an interference for. So go back and do your study tool. Whenever you do your study tool, it should just kind of take all of these, put it in a flow chart, a table, whatever is going to help you study it. But you do need to have all those things, knowing the principle, knowing what it's positive for, why it's positive, any type of interference that it has. So focus on those type of things. And if there's any type of disease that I listed, then you would need to know what disease it's associated with also. Not anything about the disease, but just that the disease would cause a positive reaction in those chem strips.